Hi, this is Nurse Inga, and you're watching Substance Use and Addictive Disorders. Some key terms related to substance use and addictive disorders are addiction, which is a compulsive and chronic requirement. The need for the substance is so strong that it generates distress if left unfilled. It actually creates anxiety when the compulsion is not filled. This interferes with the ability of the person to fulfill their role functions, both in personal relationships and professionally. They experience intense physiologic and psychologic cravings, and they're unsuccessful at attempts to stop using. They spend an excessive amount of time trying to get the substance that they're addicted to. With the pattern of addiction comes the possibility of intoxication, which is the physical and mental state of exhilaration and emotional frenzy or lethargy and stupor, depending on whether you're using a stimulant or a depressant. And then withdrawal is the physiologic and psychologic readjustment that accompanies the discontinuation of the substance and usually swings in the opposite direction. So for the person who is experiencing intoxication from a stimulant, they usually have very depressant withdrawal. And for the person who is using a depressant, they usually have a very stimulated withdrawal. For the purpose of this brief discussion, we're going to look specifically at alcohol and opiates. Alcohol usually follows some patterns of use. There's the pre-alcoholic phase where the person is using alcohol as a way to manage their stress and to deal with the tensions of daily life. After time, they develop what we call the early alcoholism, where they start to drink to the point where they're experiencing blackouts, amnesia, and tend to have significant guilt and use ineffective coping or denial about their drinking. Once they enter the crucial phase, they have completely lost control. They tend to binge drink, and obtaining alcohol becomes the focus of everything. They start to lose or destroy relationships, including work, friends, and family. When the person enters the chronic phase of alcoholism, they are intoxicated more often than they're sober, and they can experience life-threatening physical manifestations from the disease. The intoxication itself can be dangerous, but then the use, long-term use, impacts every single body system, and the effects of withdrawal are also incredibly dangerous. We have both non-pharmacological and pharmacological treatment options for the patient who is seeking care for their alcoholism. Self-help groups such as Alcoholics Anonymous can be very effective for some patients. Other patients prefer private counseling. Pharmacologically, a drug called disulfiram or antabuse can be given to prevent the patient from using alcohol because it makes them incredibly ill and actually can be fatal if they drink a lot while they're taking the medication. Drugs like naltrexone, which is a long-acting Narcan, SSRIs, Campril, these drugs tend to stimulate the neurotransmitters within the brain and tend to prevent the desire to drink. They're not sure exactly how they work, but they seem to decrease the urge and prevent relapse. If the patient stops drinking after drinking quite a bit, the CNS depression that occurs with alcohol use now kind of swings the other way, and they experience intense CNS stimulation and agitation. This oftentimes begins within 4 to 6 hours after the last drink, and the symptoms generally peak day 2 to 3, which was with the delirium tremens. That's the greatest kind of life-threatening point, is somewhere around the 48-hour mark. Signs and symptoms that are most common for alcohol withdrawal are agitation, coarse tremors, nausea, vomiting, malaise, tachycardia, diaphoresis, hallucinations, headache, insomnia, and even seizures. The seizures are delirium tremens, which can be life-threatening. These symptoms can be managed with benzodiazepines, fluids, vitamin and electrolyte replacement. If the patient can take PO medication, we use Librium or Cerex, and if they cannot take PO medications, we use IV Ativan. For the patient who has a history of difficult withdrawal, including seizures, oftentimes we'll add an anticonvulsant such as Dilantin. If you suspect a problem, the provider can order CIWA assessments so that you can monitor the patient's progress carefully. This is an example of one of the CIWA scales. So this is the CIWA Alcoholics revised scale. The first thing that you want to do when you enter the room is just get a general impression of the patient. You want to take their pulse and their blood pressure and monitor carefully for tachycardia and hypertension, which are definite signs of agitation and withdrawal. Hypertension should be reported immediately, especially if the diastolic starts to raise above 90 or 100. There's a 7-point scale here, and a couple of them only go to 4. But basically, you're looking to see if the person is experiencing anxiety, agitation, tremors, headache, confusion, nausea or vomiting, sweating, any auditory or visual hallucinations, or tactile disturbances. Then you score that based on their experiences in your assessment, remembering that things like fine motor tremors are felt fingertip to fingertip, or having them place their hands on your hands and not necessarily visible if they just extend their hands. A score of less than 8 is mild to minimal withdrawal symptoms, or none really. 8 to 15 would be mild, 16 to 20 moderate, and greater than 20 severe. Depending on the facility where you work, you will have protocols or written orders from the physician to treat the patient with medication and doses based on the severity of their symptoms and their score. Opioids are medications that are derivatives of basically the poppy plant. So they're kind of opiates in nature. The reason that they're kind of all lumped together is they tend to stimulate the same receptor sites within the body. These include things like opium, morphine, codeine, heroin, hydromorphone, oxycodone, hydrocodone, meperidine, methadone, fentanyl, and some of these are obtained legally, some are obtained illegally. There is absolutely no medical use for heroin, so that would always be illegal, but the others are sometimes received by prescriptions and sometimes received on the street. This is most likely an old statistic, but the CDC reported that 91 Americans die every day from an opioid overdose, and that includes prescription opioids as well as heroin, and I would postulate that that number is much higher. When you take opioids, they are also central nervous system depressants, similar to alcohol, but they also have those severe addictive qualities. They mainly affect the central nervous system by inhibiting suppression of the reward pathway. So the reward pathway is stimulated, but at the same time, all central nervous system activity is depressed. They have drowsiness, euphoria, analgesia, respiratory depression, cough suppression, and then oftentimes nausea, vomiting, constipation, and pinpoint pupils. When you take it in excess, there's often a rapid onset of slurred speech, impaired judgment, apathy, psychomotor agitation, depression, and memory loss. An overdose results in respiratory depression, which leads to hypoxia, bradycardia, cardiovascular collapse, and death. Opioid addiction can be treated with basically substitution therapy. And the purpose of substitution therapy is to get the patient off of unsafe medication that's being doled out by someone who could be giving them different strengths, cutting it with other drugs, and replacing it with something that technically is controlled and we know what is in it, and hopefully, gets them away from using dirty needles and helps them achieve a safer and healthier lifestyle. Those would be drugs like methadone, buprenorphine, which is also Subutex, or Suboxone, which is buprenorphine mixed with naloxone. Naloxone or Narcan is an opiate antagonist that is given to reverse acute intoxication or overdose, and is titrated to respiratory rate, depth, and effort. The goal is not to completely put the patient into withdrawals and induce seizures, obviously. The goal is just to increase respiratory rate, depth, and effort so that they don't become hypoxic and experience bradycardia and cardiovascular collapse. Methadone, Subutex, and Suboxone are dispensed at this point in time through physicians who have had special training on the management of those medications. Nationally, there is a push for all primary care physicians to start patients on these medications and then refer them to physicians who could manage them for longer term. The goal really is to get people to stop using street drugs that we have no control over and to decrease the number of deaths that are occurring from unregulated opiate use. When you withdraw from an opiate, you go from central nervous system depression to intense stimulation and agitation. The withdrawal period itself oftentimes is very painful, physically as well as mentally. It generally starts within 6 to 8 hours after the last dose and peaks within 1 to 3 days. It will subside ideally by 10 days, although many patients who have had problems with substance use or addiction will tell you that the overall desire never really goes away. The acute withdrawal presents with muscle aches, nausea, vomiting, diarrhea, that cold turkey skin where they're kind of cold to the touch, almost like the goose flesh, and kind of clammy, watery eyes, fever, insomnia. Depending on the physician, this is oftentimes treated with benzodiazepines or an alpha 2, so basically an alpha blocker like clonidine. Not opiates, but sedative hypnotics and anxiolytics like benzodiazepines also present an inherent risk to patients who use them routinely or who use them recreationally. Central nervous system depressants like benzodiazepines cause altered mental status and respiratory depression. They have an additive effect with other medications, and they have a very strong rate of physiologic and psychologic addiction, as well as tolerance that requires increasing the dose. For nurses, the biggest kind of consideration with this is that patients who develop tolerance to central nervous system depressants tend to develop a cross tolerance to other central nervous system depressants, which makes pain management a challenge. One of the things that's important, and one of the reasons that I mention the benzodiazepines here, is that clients who experience alcohol or opiate withdrawal oftentimes experience insomnia or disruptions in normal sleep patterns. Instead of using a benzodiazepine to help them sleep, one of the things that would be important for us would be to assist with sleep hygiene and a good routine, so help them to develop healthier habits. Use benzos or medications as a last resort, remembering that those too are addictive and we're trying to reduce addiction. They lose effectiveness as time goes on because of tolerance, and they interfere with delta sleep, so stage 3 and 4 sleep, when the brain actually rests. So medications that you use to help you fall asleep don't allow you to achieve deep sleep, and therefore you don't wake up feeling rested, which actually worsens your need for sleep. And if you continue to use sleep aids, you'll actually become less and less and less rested. Ambien is a sleep aid, but not a benzo. It has some severe side effects in some clients, and especially when you are weaning a patient off of another substance, Ambien would not necessarily be a great alternative. A key concept for dealing with a patient who has a substance use issue or an addictive disorder would be to think about pain management. As the nurse caring for someone who has an acute pain issue, one of the things that we need to remember is that every person experiences pain differently, and every person experiences pain relief differently. And that's because each of us metabolizes and uses medications differently. So where one person may get great relief from 4 milligrams of morphine, another person may get no relief from 20 milligrams of morphine, but might get great relief from 100 mics of fentanyl. Patients who have an addiction to alcohol and or benzodiazepines or even opiates may have an alteration in metabolism of other substances. So they develop those cross-tolerance issues and experience less pain relief, which means that they require a higher dose. Our job is to make sure that they're experiencing pain relief and to advocate for the patient. Reassess on a schedule, administer on a schedule, and use a consistent rating scale. When caring for this very delicate population, keep safety in mind. Patients who experience substance use and addictive disorders have a high risk for suicide and self-harm, as well as anger and violence towards others. Support them in their goals and their needs and provide education based on the topics that they're interested in learning about at that point in time. Always assess for readiness to learn before providing education. Utilize therapeutic communication skills and the tools that are available to us, such as the SBIRT and the audit and cage. The patient should be able to identify situations that trigger that desire to use, and then we want to help them identify healthy coping mechanisms so that they can find other outlets for their stress, their anger, their fear, whatever it is that they're experiencing. The patient should be able to demonstrate positive attitudes and behaviors towards recovery, and they look back and can honestly describe the impact that the use had on their life. And that's one of those evaluation tools that we use. Like, how do I know that this person is being honest about their use or their addiction or their recovery? And that's one of the ways that we know. So that is kind of a brief overview of alcoholism and opiate addiction, a little bit on withdrawal and management. I hope that that helps a little bit. This is a huge topic. This is really just the tip of the iceberg. And I feel like every year we get better at learning more and becoming more effective in supporting and helping the patients that need us so much. So thanks for watching. Let me know if you have any questions.